Welcome to NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide the highest quality services. According to Erik Erikson, a noted developmental psychologist, every person must pass through a series of 8 interrelated stages over the entire life cycle. NCSS provides a continuum of services to meet the needs of individuals who at any point seek assistance. NCSS's purpose is creating a stronger community, one person at a time. Now, let's get to today's show.
I'm Joe Halco, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Each month on this program, we discuss a human services topic, and we do that with staff from one of our 3 service divisions. Our 3 service divisions are Behavioral Health Services, Children, Youth, and Family Services, and Developmental Services. And on occasion, we have guests from organizations that NCSS collaborates with throughout the year. This month's episode is titled Results-Based Accountability. There's always been a lot of discussion around how to measure the effectiveness of services that are being provided. Questions have been asked such as, what would we do differently if outcomes really mattered? After all, the goal is to improve lives. What if we were able to produce measurable improvements for our community? Today, we'll discuss how that is actually being achieved and the journey that it's taken for results accountability to become meaningful and accepted. To discuss this subject in greater detail, I'm pleased to introduce this month's guests. They are Kim McClellan, Director of Operations, and Allison Cromp, Quality Review Specialist. I'd like to welcome both of you to the show this month.
Thank you, Joe.
So let's begin with the history of results accountability and what is results accountability?
Results-based accountability, or RBA as we call it, was developed by Mark Friedman. And the model helps us think and provide action on improving the lives of individuals and community health. It also helps organizations look at their performance measures and improving services for clients. The model is based on 3 key questions. The first one being, how much did we do? The second one is, how well did we do it? And the third is anyone better off? An example to answer those questions would be looking at schools. So how much did we do? How many students attended school that year? The second one would be, how much did we do? Might be, how many education models were implemented that school year? And the third, is anyone better off, might be a percentage of students who graduated high school, went to college, went into a trade, or went on for an employment. The second part of the RBA model is to help managers look at their baseline measures and what the performance measures they're looking at, but to see if they need to turn the curve, as Mark Friedman calls it. And that looks at an action plan and furthering understanding what's behind the data.
Now, you mentioned, is anybody better off? What does that information look like?
I'm glad you asked that, Joe. For NCSS, privacy and confidentiality is our number 1 priority. Personal information and individual information, protected health information, is not used in any of our RBA reporting. It looks at this example, the truancy program. Each team has a 1-pager is what we call it, and it's got the data that's shown there, the story behind the numbers. It might be looking at if the number's lower, if maybe there was staff turnover, funding cuts, anything like that. And then it talks about what works in that program. How did those numbers turn that curve? And then it also acknowledges community partners, because it's not just NCSS serving the clients, it's a community. So we're acknowledging who actually contributes to that performance measure. But also includes the action plan on what are next steps to improve.
Kim, you mentioned one thing that I think is really important, and I think maybe viewers don't realize, excuse me, and that's community partners and NCSS working with community partners, that we're not standing alone on an island with a client, that there are many, many organizations that may be wrapping services to help someone to better their life. And if you could just, so that they get a better understanding, when we talk about a situation, well, let's take schools would be, I think, a really good one, because it isn't just the school or it isn't just NCSS that's trying to help that individual. There are a group of organizations that come together to try to help, I would imagine.
Yes, community partners, even for a student that might be in a school, they might be getting services from NCSS, but they also might have people at home health helping, or DCF, or any of the other community partners in the Franklin Grand Isle counties.
And getting back to results-based accountability, when did NCSS begin utilizing it to better serve the community?
So in 1990, Ted Mabel, our current executive director, worked for the Agency of Human Services, AHS. And at that point, when he was employed there, they were starting a new program and had some grant money, and they needed to have some performance measures attached with that. So that was an opportunity where Ted met Mark Friedman and began using it with that school-based program that AHS was starting at the time. So from there, when Ted came to NCSS about 18 years ago, he brought that model with him.
So it's really a model, if you look at kind of the history of it, is, because I was going to ask, you know, over the years, how has RBA evolved at NCSS? But even looking at it before that, it's, even though Ted had met Mark, there was a period of time, I guess you'd call it a dormant period, where not only the state, but no organization was utilizing RBA at that time.
Correct.
And then you're saying that once Ted came to NCSS, he began utilizing the model here. So how has that evolved over all the years that Ted has been here?
So when Ted first began, we started talking RBA, and we started pulling information at the data we had at hand. So whatever we had in our databases, and that was before electronic medical records, so we were just pulling reports of services provided. When we started looking at those outcomes books every year, we realized it wasn't really valuable information. It was at our fingertips. So we took a step back and looked at, okay, the programs all have to report on performance measures and outcome measures to different departments within Agency of Human Services. That's about 150 measures. So they've got those measures, and then we had these outcomes we were just pulling. None of it was useful to the manager. They weren't using the information, they weren't looking at it. It didn't mean anything to them. It was just a mandatory requirement. So what Ted had done was taken a step back and had a grassroots approach and looked at it. What does the manager need? What do they need to look at their jobs, to look at the services they're providing and the clients they're serving? And we let them start some groups and have some conversations on what would it look like for them, putting those 150 measures and reporting aside, what are 3 to 5 measures that would be important to them to tell their story and to talk about the services and the clients they serve? So each manager picked 3 to 5 measures, and they started tracking those. So from there, we developed our annual outcomes report based on those measures.
So really what's happened is now the measures are being provided by those that are really the closest to providing the services and seeing what those individual clients' needs are.
Yes.
Which really enhances the information and gives you the opportunity to try to do better in the community in the future, I would
Yes.
would guess.
And then they can look at that data and make decisions about the program and how to improve the services and reach out to the clients.
Now, what do you do with this information? I mean, beyond the fact that yes, it's being collected, and yes, there are some graphs and what have you, but truly, what do you do with the information?
So right now, the managers have started in different areas looking at it on a regular basis. But from there, we publish an annual outcomes report that goes to the different departments at AHS. Also, it goes to our community partners, to our clients and our staff. We also publish it on our website too. So it's live data. We look at it live. And we've also just started publishing it and building it into a new platform called Clear Impact.
I see. And tell me more about what Clear Impact is.
Well, Clear Impact is essentially our scorecard. So it's the place where we document the great work that we're doing with clients, and it's basically the output of everything Kim just described. So it's where our program managers and leaders are going in to document what are our 3 to 5. And it's a place where we get to track historically how we've done. We get to put future projections on how we'd like to do, and basically track this over time. And also we include the story behind those numbers in our Clear Impact scorecard. So I know we have an example of one of the ones that we're using in our behavioral health division. And this one is from the Community Rehabilitation and Treatment Program, our CRT program. We have a crisis bed called Bayview, and this is reflecting the % of clients that report stabilization after utilizing this program. And I think what's important to note is that, we want accurate data. We know it's not always going to look always sky high, completely always going up. We want to know if there's blips and ups and downs, to be following that, and as Kim said, then turn the curve on it if we need to. And this is an example of a program that really had an increase in the amount of clients who were saying that they reported stabilization. And that went up in 2014, and then in 2015 it went slightly down, about 3%. And when you look at the story behind those numbers, it's so important to note that not only did we have an increase in the number of clients who accessed that program that year, we also had staffing concerns and issues with not always having as many people on hand as we would like, and the acuity of these clients was going up. And we've noticed that across the board in a lot of our programs, so we weren't surprised to find it in this one as well. And so I think we keep that in mind when we're looking at these trends to say, you know what, a 3% decrease in report of stabilization when a population is getting more and more and more and more acute, we're feeling pretty good about that. And it sort of explains to us, where we're at, and we feel like we know whether or not we're weathering that storm. And I think what's interesting is there are other programs where we can see it's not weathering as well. We have a community support program in the children's division who's experienced the same amount of increase in acuity, and we've noticed that means we're having trouble discharging clients because they're needing longer and longer treatment, where they're on our caseloads for a longer and longer period of time because of their intensive needs. And when you have a trend like that goes on for so long, we're finding our trend for wait lists goes up because we cannot discharge these clients. They have too high of a need. And so that's when once we see that trend, we're able to look, and as of right now, we're actually looking at, we've got a proposal forward to talk about a different level of care to address this issue. We think that some of these clients need a more intensive program. And so some decisions are made out of following this data, good or bad, to help adjust for what the clients need.
And I think a big piece to really think about when Allison was talking about the programs looking at their performance measures, it's a shift in culture. When historically businesses of any industry would pull those reports and they would go to their managers, your numbers are down, and it was more of a punishment perspective or a discipline perspective. For us, we had to really shift the culture that it was okay to see those low numbers because those are the ones we want to track and look at to turn that curve. So it is a different type of thinking when we look at these measures.
And you bring up a good point, Kim, about culture, and that analogy that you used about the punishment versus the we need to try to figure out ways to do things better. You know, when you boil it all down, we're serving people. You know, we're not making widgets, we're not, so, and I think NCSS's culture, if we could speak to that for a moment, which is so terrific from a standpoint of when you look at various types of cultures and organizations, the one at NCSS allows the staff to really try to find ways to help those that they're serving, even if there appear to be gaps or what have you, that they sit down and they really try to come up with innovative ways to handle a whole variety of different situations that other organizations might not even try to probe. I think a lot of that comes from what you're saying, which is all numbers are not going to be positive. We know that. That's understood. But you try to work on them and do the best that you can to bend the curve.
And I think that's where the RBA model really helps that, because it allows the staff not to look at just the numbers in isolation or look at that graph. It's what is that story behind the numbers? And that's the biggest piece. And that makes it okay to look at some numbers that we want to turn.
Well, you know, when you talk about story behind the numbers, Allison had mentioned like staffing as an example. Staffing can have an impact on something that you're doing because of the acuity rate of someone. Where if you were totally staffed at the time, maybe things would have been a little different. I mean, there's so many factors that go into what a number looks like. And I think the fact that we're looking at those stories behind the numbers is critical, because it gives people the opportunity to really get a good sense of as to the why. And when you talk about are people better off, at least you know what the trail is to get there, as opposed to just looking at a number on a piece of paper.
I think it speaks to the leadership at NCSS that nobody's saying, just tell me the good stuff, you know, gloss it over for me so I can go out and, you know, shout only the good stories from the rooftop. They really want to know from the ground up where things are at literally, because that just gives us that base, you know, the starting point, and then we go up from there.
Yeah. So all of this sounds wonderful for programming management decisions. However, are there other tools that you use other than results-based accountability to show if anyone is better off?
Yes. The Children's Division has entered into Integrated Family Services. And a big implementation that's gone through there is using the Child and Adolescent Needs and Strengths Assessment. And it's one, I'll warn you, I get really excited about talking about the Child and Adolescent Needs and Strengths Assessment. We call it the CANS, and it's starting to really gain traction across the state. But this is one measure that is something we really never had before, that's given to every child and family coming into our Integrated Family Services program. So everyone gets it across the board, and it's an assessment of their needs and strengths. And they get it when they come in, and then we redo it every 6 months. And it's a way to track the actual progress of what the family and the treatment team are identifying as the needs. So we do that in partnership together. It's part of our treatment planning, but the difference is, instead of just having it be part of our treatment planning in a conversation, we're then documenting some data points. So we're taking 50 data points on things like sleep and, you know, attention and oppositional behavior, and a wide variety of things that also include caregiver needs. So does the caregiver have enough natural support? And so we're taking these data points, and the important thing about that is then they can be compiled. So we can compile those data points for programs, we can compile them for a family, we can compile them for Vermont. So it's really giving us an opportunity to speak about numbers that the families and clients really care about, because it's about them and what their needs are. And I think we have a slide that shows what that can look like. And our goal with this was really to put it in graphs that are easy for people to understand. We've sometimes had a history of using assessment tools that clinicians like or researchers like. But families are looking at it saying, you know, what's a T-score? What's, you know, and there's a lot of lines and a lot of different things. And I would say we're in the human services field. A lot of our staff get confused looking at these. It's not just families that, you know, not all of us were statistics majors. So we created these pie charts, and it really tells you, you know, out of a whole picture, and talking about the wellness of the child and family, what percentage of their needs are on fire, that need an immediate intensive action? What percentage of them are needs, and that we'll make a thoughtful plan for? What percentage are watchful waiting, and that's the green category. So, we're keeping an eye on it, but it's not reaching the level of needing to do something about yet. And then what percentage is no evidence of a need? And so that's the yellow. And so the goal is we're trying to create as much green and yellow on this pie chart as we can. And families get to see a very simple chart over time of seeing we were looking for blue and red to shrink and green and yellow to get bigger. And that's a sort of an easy way to look at an overall picture of wellness and how are we doing in our progress. And that's the simplistic version. We then can drill down as much as we want. So we can have a ton of fun with this data and look at, all right, yes, overall it seems my child is doing well, but as a parent, their oppositional behavior is still driving me nuts. Where are we with that? So we can give them that data point as well. Well, they were at a 3, they're at a 2 now. I know that's still, we still have some work to do. So we can give more detailed information, but on the report, we're really looking at, overall.
Yes. Now, Allison, you mentioned integrated family services, and I think that's so important because that's something that's different. NCSS is one of only 2 organizations in the state that is piloting it. But when we're talking about what we are, which is results-based accountability and all of these other tools like CANS, and you talk about this IFS model, what I see, there's a beauty here because integrated family systems gives our staff the opportunity to do some things that they couldn't in the past. Could you speak to that a little bit? Because I think it's so important when a family has a child and they come to NCSS, what is all this going to mean? And what do I need to do as a parent to ensure that my child's being taken care of? And I think what IFS has given our staff the ability to do is to break down a lot of barriers and silos that used to be there. If you could just speak to that and why that's so important and what we have found since being involved in this pilot.
Absolutely. I think one of the biggest things is historically, as you just spoke to, things were siloed. So you were eligible for a program, and those programs had detailed things that they did. There's a list of here's what we do, and they often had reporting things that this is what we're responsible to do and to report out on. And then if you were in a different program, there was a different list. And it really created what happened a lot of times. As we know, humans are complicated, like you said. And so child or family may start out in one program, may need another program added, or they might transfer to another program. And all of a sudden, we're measuring things differently. We're talking differently. We have different goals and agendas. And it can be really confusing for families, for clients. It can disjoint your care. And we found we're sharing a building, we often didn't know exactly what other programs were doing. We had so many obligations to our own reporting structures and our own things that we were accountable to that we didn't have a lot of opportunity to talk the same language with each other. And we've noticed that a lot with our partners, schools and DCF. They were having to get to know each individual program, what it can do, what it can't do. Here's what you can get. And it was things were more limited, it seemed. And I think what we've noticed now is now that we're talking about a kid as a kid as a kid, as they said a lot of times when we started integrating family services, people didn't have to memorize this stuff so much anymore. It was come into our services, we are going to assess the level of need, and we're going to talk about these kiddos in the same way in terms of what are their needs and what are their strengths. And that way, when we've developed this CANS assessment, I know DCF especially was relieved to say, oh, so you're going to give me back a document that's plain language? That's just, here's what the kiddo needs and not something specific to, we had IFBS, for instance. It would have very specific language on. So it really kicked the door open to start using more universal language and create more universal goals, which I think has been really exciting for staff. They feel freer to do what they need to do.
Well, and the thing is, everybody is in this to help the child. And if you have all these restrictions and barriers and what have you, it makes it rather difficult to try to do that. And this, at least, like you said, relieves a lot of that, and it gets back to the point of focusing in on what is going to be the best for that individual in their particular circumstance, which I think sounds exciting.
Yep. And I think families have found it to be exciting. And that's been, I will say, the reason I get excited about it is because, for that reason, staff like it and families like it. And I think one of the reasons they do is because people like to be a part of their own progress too.
Yeah.
So it's exciting for them to get that 6-month review and say, oh, geez, I guess things really have moved in this direction. Oh, we still need to work,
Sure.
But they get a chance to see that progress and what they've been doing on paper. And I find that to be really motivating for a lot of people.
Yeah, that's good stuff. Now, are there other organizations in the state that are utilizing either results-based accountability or the child and adolescent needs and strengths assessment?
I think in the last maybe 3 years, there has been movement to work towards using the RBA model. There are 10 designated agencies and 6 specialized service agencies that come together as a network. So the 16 total agencies have been pulling in their own county data and putting that into an annual report to answer the question, are Vermonters better off? And so we are working on our 3rd report now to talk about the services provided to all Vermonters.
And speaking of that, the efforts throughout the state collectively to look and answer that question that you just said, are Vermonters better off, is how do you see that evolving because of what other organizations are starting to do, Kim? I mean, is there any kind of a roadmap or anything that you can kind of share as to what that looks like?
I think with all 16 of the agencies using the same framework and talking the same language, we're able to show and talk about the value of what we do, and we're able to talk about the progress people are making. And this is just helping in the bigger healthcare reform conversation and preparing for changes that might be coming.
Because certainly healthcare reform is an immense topic and one that everybody is trying to get their arms around. And certainly an organization like ours and what we provide, it's so critical that we be our inherent part of this reform so that the whole individual can be served, as opposed to having physical health and mental health separately.
Because the RBA structure does talk about the community partners, and that's a big focus, and so is healthcare reform. They're not looking at a person just going to one entity and getting services. They're looking at it as a community supporting the individual. So it is a different approach.
And with that, that's a great way to wrap up this month. I want to thank my guests, Kim McClellan and Allison Cromp, for being on the show today and sharing their insights on results-based accountability and how utilizing this and other tools will help the Population Health Initiative. I also want to thank you, the viewer, for spending time with us again this month. You can learn more about NCSS and all of our programs and services by logging on to ncssinc.org. I'm Joe Halco, and I'll be back next month with another episode of NCSS Here for You.
This has been another episode of NCSS Here for You. We hope that you found today's discussion informative and educational. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. Thanks once again for tuning in this month. NCSS's purpose remains creating a stronger community, one person at a time.